my name is Mitch Guthrie, and this is the Long Letter Podcast, episode 22. And this episode is dedicated to syringe service programs, Sean Swope, and what I'll call punitive public health policies. But before we get into this, I'm just going to give you a warning. I'm going to be talking kind of fast. I'm going to be kind of going through a lot of information here because there's a lot to get out. And the reason why I'm talking about syringe service programs, SSPs, is because we have a proposed ordinance in our area, Ordinance 1354, which seeks to add regulations to SSPs. And that in and of itself is not a bad thing, but I do want to highlight how weird I feel like the conversation has been around this, the process that's been around this, and maybe some of the underlying factors that should give us pause and cause for concern with how this is being handled. And so when you hear me talk about SSP, syringe service programs, I'm going to quit saying syringe service programs, hopefully, here, but SSP, what I'm referring to is what you may have heard of as a needle exchange or a syringe exchange. And when we look up the definition, like what's the purpose of an SSP? Well, the National Institute on Drug Abuse has these highlights on a syringe service program, which is syringe service programs are community-based prevention programs that can provide a range of services, including access to and disposal of sterile syringes and injection equipment, vaccination, testing, and linkage to infectious disease care and substance use treatment. Nearly 30 years of research shows these programs are safe, effective, and cost-saving tools that can prevent HIV and high-risk injection behaviors among people who inject drugs. Syringe service programs help protect communities by preventing infectious disease outbreaks and facilitating safe disposal of used syringes. These programs are not associated with drug use, crime, or syringe litter in communities. And then the third point they make here is the most effective syringe service programs provide comprehensive services to people who inject drugs, including the distribution of life-saving medications and referrals to substance use treatment and other care. And so in Washington state, we have 39 counties. Out of those 39 counties, 27 have some sort of syringe service program. Some have multiple programs, and some of those are even run by local municipalities or jurisdictions like the county or whatever. And so according to the Department of Health, they've got a breakdown here of SSP benefit, the SSPs and their benefit to communities and public health. And they've got 6 points that they kind of make here. And I'm going to try to provide all this documentation, even though it's easily Googleable. Googleable? It's searchable. It's searchable. You can go search for it. So the first point they make is SSPs provide free sterile syringes to people who need them in order to reduce syringe reuse and sharing. SSPs also offer safe syringe disposal for used syringes, and SSPs do not encourage or enable drug use. The second one is that SSPs can offer screening for infectious diseases. Third point is SSPs provide opioid overdose prevention, education, and distribute naloxone. The fourth is SSPs provide referrals. And the fifth, SSPs are a critical HIV prevention intervention. That's just fun to say. SSPs, 6 point here, also access people not engaged in traditional healthcare. And that's pretty critical. And so I also looked up the CDC technical package on SSPs, which was published in 2020. And a technical package, it's a technical package of effective strategies and approaches for planning, design, and implementation. It has like 5 strategies in there, and each contains several approaches under a strategy. But I'm only going to touch on a few because I think they have merit with the ongoing conversation that I'm going to include you on here in a little bit. And so under strategy 2, SSP planning, design, and implementation, the first approach is that needs-based syringe distribution is the best approach. So they say, although restrictive syringe distribution approaches such as one-to-one exchange may seem desirable, in fact, they are associated with increased syringe sharing and increased risk of infections among people who inject drugs and are therefore not recommended. In addition, people who inject drugs also face multiple barriers to care. SSPs should strive to address such challenges and provide low-threshold access to services. So my point in kind of bringing this out is it will come into play later as you listen to some of the debates and discussions that were ongoing on this topic regarding this ordinance. And then in the same technical what do you call it, technical package or whatever, they have strategy 3, which is core versus expanded services. And I want to draw attention to this because I feel like this puts guardrails on what an SSP is, what it should be expected to do. And that's going to help you if you can hold it in your mind for the conversation that's going to unfold here. So basically, syringe distribution and disposal options are core SSP services. Then there's expanded services complement those core services, and they improve people who inject drugs. They improve their health and well-being. So while SSPs provide all core services, ideally and when possible, expanded services can also be provided. So I want you to keep that in your mind. What is an SSP? It's simply a program for clean needle exchange that is intended to reduce the transmission of blood-borne pathogens, both in intravenous drug users, community and their larger community as a whole. That's it. That's what this is about. And SSPs have core functions, core services, which has to do with clean needles and disposal and all that other stuff. And then they have what they call extended services. You'll also hear these referred to as wraparound services. And so that's kind of the nutshell of an SSP. You can go look it up. If you don't trust that I'm telling you this, I will provide the documentation I am reading from, and we can kind of move into what this all looks like. And so the CDC also has a document that they published in 2018 that's evidence-based strategy for reducing opioid deaths. And it's got all sorts of stuff in here. This also comes into play in this conversation, but it basically has evidence-based strategies that, as it says, are for preventing opioid overdose. Ugh, that's hard to say. Anyways, those are things like targeted naloxone distribution, medication-assisted treatment programs, so much stuff, 911 Good Samaritan laws, whatever. But at the very bottom of this document, syringe service programs. And so they talk about why this is important. And the research, I'll link to this document, but the research here says syringe service program participants are 5 times more likely to enter drug treatment and 3.5 times more likely to cease injecting compared to those who don't utilize these programs. Syringe service programs are more effective at preventing disease and maximizing service coverage when distribution rules are less restrictive, such as when the program is distribution-based, not exchange-based, and when distribution limits are high. And a key element to success of syringe service programs is reducing disease and overdose, and in connecting more participants with care is the refocusing of public health or public responses to drug use away from criminal justice approaches, which discourage safer drug use behaviors and requests for help. It said a recent study found that individuals who use drugs who were recently incarcerated are at significantly higher risk of overdose and are more willing than their non-incarcerated peers to receive training for and administer naloxone when this is offered by syringe services programs. Making syringe service programs a particularly important intervention for assisting these high-risk individuals. And it goes on and on and on. There's just a ton of information. I would definitely encourage you to go, I can't believe I'm going to say that, go do your own research and look some of this up. So this brings us to Ordinance 1354. And I'm just going to highlight the ordinance because you're going to hear plenty about it in the conversation that follows. But one of the things I kind of want to point out right at the beginning of the declared ordinance. In the ordinance, it says, under creation and purpose, sterile needle and syringe exchange programs offer the exchange of clean, unused needles and hypodermic syringes for used needles and hypodermic syringes as a means to reduce the transmission of HIV, AIDS, and viral hepatitis or other blood-borne diseases, decrease the number of improperly disposed needles and syringes which pose a serious risk to the public health, safety, and welfare, given the potential for possible bodily injury, property damage, blah, 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 blah. And to provide a first point of contact for formal drug treatment, access to health and counseling service referrals, the provision of up-to-date information about safe injecting practices, and providing a means for data collection from participants about their behavior and or drug use patterns. So right there in this ordinance is the sort of scope, the guardrails, if you will, on an SSP. And so the ordinance has a couple things that will be covered as we look through the meetings that were on this. But one is registration. We require SSPs to be registered. It says that all staff, volunteers, and any other individuals cannot have been convicted of a drug-related offense in the past 24 months. So that's an interesting restriction. Locations must be fixed in a brick-and-mortar building, no mobile. Must be within 750 feet of a school, park, or library. The operator shall operate a one-to-one exchange. This kind of changed a little bit where more than 10 needles switches to a good faith estimate. So if it's under 10 needles, you provide one-to-one. Otherwise, it switches to good faith estimate. Age restriction to those under 18. ID is required if there's a question. And under penalties, any commissioned law enforcement officer or Lewis County Director of Public Health and Social Services or the director's designee or the prosecuting attorney may inspect the site of the sterile needle and syringe exchange program. And then a third violation and all subsequent violations of this chapter shall be a misdemeanor. So these are kind of the, I call them hot button topics, I guess, for this ordinance. This is kind of the things that are unique in this ordinance and what carried a lot of attention and time. And so this topic, this ordinance in particular, was discussed, as far as I can tell, in 6 public county meetings. The first is on January 8th, which is the BOCC, that's Board of County Commissioners wrap-up meeting. So in this meeting, they kind of set the stage for what they're going to vote on the next day in their business meeting. And this is where, as far as I can tell, the draft ordinance is first introduced in any public meeting. And Swope requests that it be added to the January 9th BOCC business meeting, which is the next day. And this is a notice of hearing. So basically, this posts it and allows the public to have access to it in case there's any concerns or if the public wants to respond to it. The whole point is just to give the public a chance to see it. It gets motioned and seconded, and then so there's 2 commissioners in the room. There's Brummer, Commissioner Scott Brummer, and then there's Commissioner Sean Swope. Pollock was not expected to be there that day, and yet she shows up in this meeting, and to me, it's kind of funny. I'll play you the clip of when she shows up here.
We add resolution 24-001 to 024-01 to the January 9th, 2024 business meeting.
Second, all those in favor?
Wait, I have some considerations on this.
No, sorry, Commissioner. I didn't see you were online there.
Basically, she shows up to the meeting unexpected. Honestly, this just kind of has a whole oh, hi, Mom, we didn't know you were going to be home. How long have you been standing there sort of vibe to it. But she does have concerns about the draft. And she wants to know, have we heard from the Public Health and Social Services Advisory Board on this? She had some concerns about the definition of controlled substance, the location restrictions of SSP programs, how that might affect rural areas. Would this prevent any kind of controlled needle exchange? There was an age restriction that she had some concerns about and the health implications for that, because if you deny that particular age group clean syringes, are you increasing their risk for bloodborne pathogens? The counting of syringes used. She said she'd love to hear from the public health community on this. As close to one-to-one is ideal, but she also wanted to make sure that things were set up so that they minimize unintended consequences. And here, Robert Bradley responds on the legal matters. And this is going to be kind of a recurring theme. So Robert Bradley works for the prosecuting attorney's office. And his job was to draft this ordinance, as far as I can tell. And we'll get into that a little bit more. But as it is, he can only really weigh in on whether something is legal or could be legal. He can't really, doesn't have the expertise to say whether it should be done or what's best practice. Anyways, all of that said, it leads to this sort of, I don't know what to call it, awkward exchange here.
The purpose of a notice of hearing is to give the public access to what is supposed to be the final document.
I've sent it to our over at the the jail, not the jail, but the sheriff's office, and I've gone over and talked to one of our judges about it as well, and haven't.
I repeat, the notice is so that the public has the opportunity to view what is supposed to be the final document.
And I guess my concern is that we might just be a little bit ahead of our discussions with the Board of Health, the health officer, and then our advisory board as well.
I'll resend it.
Okay.
All right. So this is something of a point of order here where it's just like Pollock was saying. The idea of a notice of hearing is that the public is getting access to the near final form of something, and that wasn't really being followed here. And so she kind of basically states that. And it was kind of weird that Swope was like, well, I took it over to the sheriff's office or a judge and the process. Like, that's not the public. I feel like he should know that. I'm kind of surprised in his response, like a little bit here. And so, yeah, this is just one thing in many things that are going to come up as we kind of walk through this. So it gets rescinded. And then there's the January 8th Board of Health meeting. So this is the same day. And I don't have a recording of this, but according to the meeting minutes, Commissioner Brummer requested that Dr. Wiley work with entities that provide needle exchanges to learn more about the process. So Dr. Wiley is the county's public health officer. He's kind of the authority on this. He's the one that should be driving these types of policies. So this was just Brummer's request that, he work with entities and learn more about the process. And so then we get to February 21st. This is the director's update. And Robert Bradley once again proposes this draft of the said ordinance 1354. And there's a few things to note, which is one, at this point, February 21st, in this director's update, this still hasn't been reviewed by the advisory board, and it's not in its final form. And so, once again, Pollock has some concerns.
So the question about the penalties portion, usually medical type facilities are investigated by Health Professionals Quality Assurance Commission. And so I was wondering how it works where we're trying to write something where it's going to be commissioned law enforcement officers or prosecuting attorney, and how that jibes with the usual process in health related matters.
Regarding that particular subsection, I would just refer the board to the RCW 69.50.612 subsection 2. It says nothing in this chapter shall be construed to prohibit cities or counties from enacting laws or ordinances relating to the establishment or regulation of harm reduction services concerning drug paraphernalia. So I believe legally we could put it there.
All right, I'm going to stop it right there. That's Robert Bradley, once again, from prosecuting attorney's office, or prosecutor's office. And her question is like, why is this in here? And his response is, well, we can legally do it, which is really like kind of his refrain through a lot of this. He can't give a why. He can only say if that's legal or not, to the best of his ability. And so, yeah, and it gets into an important part I want to draw here, which is, Bradley can only give guidance on the legalities of something, or at a minimum, what the county can perhaps legally defend, but he has nothing to offer on policy. Pollock brings up other things that she's concerned about. She was looking for exemptions for pharmacies and feed stores, which also give out syringes or sell syringes. Would these, penalties be imposed on them? And, she kind of ends this whole thing. I mean, the fact is that you can order all this stuff on Amazon. Brummer, he points out that this is obviously a draft. He forwards this to the Public Health and Social Services Advisory Board, and he kind of, he wants them to have a robust discussion on it and a debate, and he wants them to talk about this particular ordinance, but also harm reduction across the board, and, just have them weigh in on this. He recognizes it's a process, and so he thinks pushing it out 3 weeks to March 19th for a hearing is the best way to go. And at this point, I just want to point out that the original draft that is currently online is the only copy publicly available is this version, one of the kind of the first versions to be brought forth. And so now we're going to shift into another meeting. So we've gotten, I think, 2 meetings down. We're at this advisory board meeting, and this meeting is long. It's 2.5 hours long, or near 2.5 hours long. And it was really hard to try to capture what I thought were salient points in the discussion. I tried my best. I also can't always tell who's presenting. Some of the voices sound the same. And so I did my best. But in attendance here, you have Teresa Echtel-Johnson, Elizabeth Rohr, Galen Spradley, Kate McDougall, Wynn McHale, Ryan Barrett, Joe Wiley, John Alplenalp. I hope I said that right. Sorry, John. Robert Bradley from the Prosecuting Attorney's Office, and Dr. David Ellis and Lori Davis and Angela Iverson. So these are the people that make up the board. Obviously, Ryan Barrett is the county manager. Joe Wiley is the public health officer. John Alplenalp is the director of health and something. But the rest of them are all board members. And so the chairman of the board is Jamie Lund. And he starts out, I feel like, in a very, I don't know how to, I'm impressed with how he handles this. So his first kind of point of order is to figure out just like what the heck they're doing there, what they're supposed to be doing there. So he kind of tries to put some guardrails, and he asks some questions about what they're supposed to be doing.
I'm merely expressing my preference that we get a written, like, here's what's on the table, here's what's off the table, and that it's actually voted on, not like, hey, I got this idea, I guess that sounds all right. We understand what the direction is, and we will act accordingly. My preference in the future is that we would get something which gives us the edges of what we're to talk about. Because in thinking about the conversation today, how many things could we talk about, and what is the deliverable that we've got, which is the next piece of the conversation. We are asked to provide comments, we are asked to provide questions, and the word proposal or recommendations is also included there. And I don't know whether we are asked, shall we adopt this ordinance as is? I don't know whether we are asked to amend this ordinance and propose an alternative to them, or whether we are to have a conversation, capture elements of the conversation, and reflect those in the next meeting on a more informal basis. My hunch is that it is the latter of these, since we don't have a formal directive to provide a vote on this particular ordinance. At least our recommendation be formalized in that way.
All right. So this is Jamie Lund's attempt to try to put some guardrails on it, and ultimately he decides the board's going to do 2 things. One is that any questions from any board member will be documented and returned to the Board of Health. Now, the Board of Health sounds confusing, but it's actually just the commissioners. So what they're going to do is put any question that any board member has together, that goes back to the Board of Health, and then 2, a series of statements that are voted on by a majority. And it's here that Robert Bradley also clarifies that he will not be commenting on policy issues, only on legal issues. And Lund clarifies here that he's only putting forward consensus items and questions. And so this is kind of what I'll call the guardrails that Lund puts on. And I got to give kudos to Lund. He's a very systematic thinker, and I don't know if somebody without that skill would be able to have produced really anything out of this meeting the way he managed to get out of this meeting. He did a very good job. I don't really know how advisory boards function, and I was very impressed with kind of the way he tackled this and systematically went through it. So those are the two things: capture the questions, and then they're going to do a series of statements. And he starts at a more general, broad scope, and then it gets more specific as they dial it down. I will note, though, that it never actually gets specific to actually referring to said ordinance, and we'll get into that. So next is public comment with Cole Meckle and Patty Howard. They're there. And so I'm just going to play Cole's presentation because I think it just captures everything better than me relaying it. And as the only SSP service provider in the area, they're directly impacted by all of this.
Do we have a drafter? Are you the drafter, Robert, of the ordinance? So can you speak to questions if there are any on the language?
Oops, never mind. That was the wrong one. So let's get to this one here. Here we go.
A couple of things. One, I would just love to have any of your questions along the way, if that is appropriate. I'm more than happy to discuss any SSP concerns, questions, ordinance questions, or concerns that you have for sure. So a few things that I just want to make sure that people are aware of. One is that we have been operating an SSP in Lewis County for, how long has it been now? Since 2019. We have operated that always as a mobile unit. When we operate it, we have a lot of wraparound services that go out with us. So it's not just syringe exchange. We also supply other harm reduction goods, from socks to Narcan, naloxone. We also have a nurse that goes with us. We have peer care navigators that go along with us. We have a counselor that goes with us. So there's a lot of referrals that come out of the contact that we make. A lot of people that are IV drug users are not all that interested, unfortunately, in just showing up for those resources. They are wanting to come and exchange syringes. And so it's very important, among other issues and other positive things, very positive things that I can cover just briefly in a minute, that this is a point of contact for people that otherwise would be stuck in their camps or stuck in their homes, people that would not have any other reason to venture out. And so I would just want to put that into your ears, because it's not one of those things necessarily that people think about when it comes to syringe exchange programs, but it really is an opportunity to engage with individuals in communities who would otherwise be very difficult to reach because they don't honestly have much of a reason to come out. And many, many of our individuals in Lewis County and throughout our state that use IV drugs use them in their homes. Over 60% of the people that we serve are homeowners or home renters or people that live housed. It's not this stereotype of folks that are living unhoused. It is a percentage of people that we engage with, certainly, but it's not limited to folks that are unhoused. So some quick data, and I can send you links for any of this. Syringe litter in areas that have SSPs is reduced, the data shows, by 86%. It's very counterintuitive to what most people think about syringe litter. They think it increases when you have a syringe exchange. The reality is all research demonstrates that it lessens syringe litter by 86%. It provides safety training that allows people to be 3 times more likely to stop using IV drugs when they have. Part of it is that face-to-face contact with somebody that can help you connect with resources that can point you in a direction of recovery services. For us, we oftentimes have those recovery services available to start that same day that we might meet somebody if they're willing. Many times it takes a while, of course. People that access syringe exchange services are 5 times more likely to seek treatment than somebody who's not engaging in an SSP. Again, this is because of that face-to-face contact with people. 3 times more likely to stop using. These are people that are accessing syringe exchanges over and against those who are not. It becomes a test point for people that need to have HIV and hepatitis C testing. So not just slowing the spread of disease by not transmitting from syringe to syringe and syringe sharing, but those people that we're reaching and talking with are able to get tested. We have rapid tests available, confirmatory tests available. In the last year, we not only were able to do confirmatory tests for 32 people, but 6 of those people we were able to walk all the way through case managing them so that they were able to get treatment and be healed from their hepatitis C, which, by the way, saved taxpayers just around $850,000 by not having those people having to access healthcare for the ongoing chronic problems of hepatitis C. It costs us, as far as in-kind syringes that we access through the Washington State Department of Health, less than $20,000 a year. Way less than $20,000 a year, actually, to run that program. That's what it actually costs as far as to the taxpayer. Everything else we cover, we figure out other ways to not burden taxpayers with any dollars. So HIV risk and spread of risk is lessened by 50%. If you haven't had a chance to go online and look at this, I implore you to take a quick peek at Scott County, Indiana, that saw a spike in HIV positive cases from 2014 to 2015 when they started more restricting syringe exchange access, from 23 positives in their county to 244 positives in 1 year, in which case they stepped in and legalized syringe exchange, and they saw it decline to 47 positives in 2016. So again, naloxone distribution, since we've started distributing naloxone, we have distributed over 2,000 doses, and we can confirm that over 300 reversals of death have been because of those naloxone distributions. And those are people that most likely would not be getting that naloxone if they weren't showing up to exchange syringes. Because again, unfortunately, addiction by definition is somebody who is going to do something despite the negative consequences. And so they will show up oftentimes to get a clean syringe, but they're not necessarily going to show up just to get naloxone or Narcan. But we can save lives and give people more chances and opportunities and relationships to ultimately connect people with resources. I'm concerned that this ordinance, as it currently stands, is going to be extremely restrictive, especially to the most needy of our community and our county, because as vast and widespread as we are, it's not realistic to set up brick and mortar all over the place in this state, and it's unrealistic to expect people that are struggling with IV drug use from Morton and Packwood and PL and Randall to drive to Centralia. So and again, I'm more than willing to have all kinds of hard discussions. I get that a lot of this stuff is pretty counterintuitive, especially if you've not been involved and been around it. And it takes a little time to really kind of understand what harm reduction does and what the psychology of it and the philosophy of it. It really does take some time. I'm willing, call me, email me, anything, more than willing to talk.
All right. So that's basically Cole's presentation to the board and what follows to the advisory board. Mind you, this is the board that's been tasked with advising on this particular issue. And so it gets into all sorts of stuff here, which is great. The board member Rohr asked questions about some of the definitions that Cole shares. Spradley discussed who regulates needle exchange, which is the state and the Department of Health. What would the impact of removing your mobile exchange be? It would be, pretty impactful. It'd basically have to keep it at 727 or find another brick and mortar building to operate from. And then Cole kind of points out how fentanyl has actually changed things immensely, given that it's typically a drug that is smoked or snorted. It is not injected. And so a lot of the surrounding issues with that are unrelated to SSPs. And so then Spradley is asking also, about the 2-year requirements, which would be that if a worker wants to work in the SSP, that they have to be 2 years from a drug conviction, which isn't something that Gather currently has. Discussing on registration, and Cole points out that he has lots of questions about these things too. They're not like just obvious what it is referring to or how it would be implemented in the ordinance as they had it in front of them. And Spradley also wants to make sure that he understands the guardrails well enough, and that's where there's a lot of ambiguity. So, more questions are things like how does this affect law enforcement? And this kind of goes back to Bradley and. He kind of weighs in a little bit there. Lots of questions, though. There was a question about decreased IV drug use, and there's some stats that they share They also give out sharps containers. Technically, they go for a 1-for-1. They utilize Stericycle to pick up their biohazard. And so there's some metrics that they have there by weight that they could also refer to. And then they also have guides regarding close estimates, like how many can you fit into a pop bottle or other types of containers that they see. How much testing do you do? And this gets into a lot of like hepatitis C testing and so on. And I felt like the board was, obviously this is kind of exploratory. They're asking a lot of questions about it. And it was a good conversation. It was noted, though, that, because of the fentanyl crisis, there's been a radical decrease in the need for syringes. Heroin is just not as easily available as fentanyl has been. Cole basically says that Gather works with evidence-based practices on everything they do. They talk about the age restriction limit. There's no policy that Gather has right now. They asked, do you see people under 18? He said, no, it's not really an issue. All sorts of stuff. And then there's a little bit into drug paraphernalia discussion. I think this is actually going to be kind of important in the greater conversation here. But obviously, like a syringe is considered drug paraphernalia, but at the state level, it's been, if it's for harm reduction purposes, it's not considered drug paraphernalia. And I think what this ordinance is wanting to maybe defend is that, the cottons, these little cotton ball BB things that they use, sterile water or in some sort of vessel, what they call a cooker. These are also things that are distributed through an SSP because they also impact the, what do you want to call it? Bloodborne pathogens, the spread of bloodborne pathogens. So it doesn't make much sense to give somebody a needle, but if they're going to reuse a cotton from somebody, that's going to just negate the clean syringe. Same thing with sterile water. Why sterile water? Because otherwise they'll use water that they can find somewhere else that might not be sterile. It leads to more worse health outcomes. And then the vessel cooker, same thing. So these are also what would be called drug paraphernalia that's handed out. I think Jamie Lund somewhere in this meeting makes a joke about, am I carrying drug paraphernalia if I have a cotton ball in my pocket? I mean, is this really how this goes? And, I think they don't really actively talk about it so much, but there are, I think, complications or considerations that need to be around, like drug paraphernalia laws. This is very odd. But at the state level, according to Bradley, the state, has declared that syringes for the purpose of harm reduction are not paraphernalia, but then he, based off of his claims, things like cottons and sterile water and a vessel, those things may be. So like if a cop pulled you over, you would, pulled you over if you're walking down the street or something, the cop might not be able to bust you for your needle because it's for harm reduction and not to get AIDS or hepatitis C, but they can bust you for all these other things. So then that kind of ends the questions section, I guess, for Cole and for Patty. And at this point, they can't interact really anymore. The advisory board is kind of on their own path here because public questions and comments is done. And so we then move into this discussion, and a lot of this discussion is kind of directed at Robert Bradley. He's here representing it, and I want to point out again that he can't really weigh in on why something's in there, only whether it's legal or not. And I think this is let me see if I can. I think this comes into play here in a very odd way. He has to kind of repeatedly say over and over again that, well, here, I'll just play you a little montage.
I'm not going to answer any policy questions.
Right. He's already indicated he's not going to answer policy questions.
That's a policy question. Probably the best thing to do is show up to Board of County Commissioners and ask them the reasoning on the policy. I think that'd be more of a policy question. At which point I said, I'm not going to answer the policy questions.
Right. Yep.
Okay, so that's 5 or 6 different times when he just repeats that he's not going to answer policy question. And why am I drawing this out that he continually has to state that he's not answering policy questions is because I feel like somebody who drafted this and knows why the policy in there should have probably been at this meeting. You have an advisory board that's able to ask questions of, say, the service provider, but they have all these other questions like, what's the justification for this? Why do we see this in here? And repeatedly over and over again, the only one that is some sort of authority on why this proposal exists, why this ordinance exists, can only answer on the legality of something. And it leads to kind of the next clip that I have here.
What I've done is the policy was brought to me and asked to draft a code that I thought would be legally defensible if challenged.
So here, I think, is a pretty important tell. Everybody's wondering where this thing came from or what purpose it serves. And from Robert Bradley's perspective, he was approached, and I'm going to guess by Sean Swope because he's the only one that brought this forward, or I had mentioned this, talking with the sheriff's office or whatever. But basically, the charge wasn't driven by some sort of issue in our community, some sort of emerging issue or emergent issue, or even by our public health officer or the advisory board having, say, done some work on understanding harm reduction, and here's some policies that they want to see. No, what kicked off all this process appears to be Swope going to Robert Bradley and saying, what can we do that's legally defensible? That seems to be the genesis of this whole thing. And I think that's pretty telling that this was shopped around under kind of this idea here to address like what legally can we get away with versus, oh, here's this problem, or here's what our advisory board has concerns over, or here's this issue that cropped up and we need to address it. Yeah. And so more questions come about. Also, they touch on policy questions. The advisory board starts to pick up pretty quick. Like there's just not a lot outside of legal issues that we're going to get out of the only person here that was a participant in the original creation of this ordinance. But then board member McHale does ask some interesting questions regarding badges. So one thing I didn't mention earlier was that this ordinance requires, at least the version that they're looking at would require issued badges to every participant or everybody working for the SSP that they would have to wear at all times while they're working at the SSP and so on. And so McHale turns and kind of asks about funding for this badge requirement.
I'm curious about the fiscal impact to the Public Health and Social Services Department for providing ID badges to program staff and then potentially having to go and check those badges. That seems like an administrative barrier, and I'm curious what the fiscal note might be on that.
So that is us to speak on. So we are in the process of looking at standard operating procedures and then also what the fiscal impact could be. But of note, we do not currently have persons dedicated to provide that said service, the background checks, the ID badges and these other things. We do not have specific funding through our Public Health and Social Services grants and funding. There is discussion around that funding being utilized from the opioid settlement because that does fit the criteria of the opioid settlement. But right now we don't have that as part of our built budget.
So if the ordinance were to go through as currently written, there is currently no funding and no staff and no standard operating procedures to conduct, creating badges, going out and checking them. That would have to be an additional cost where funds would have to be found.
Correct.
Okay.
So after the badge program funding discussion, Spradley goes on to ask about state level regulations.
Any other parallels, health services that the health department currently monitors, oversees, regulates, registers?
The food service program is an example of that. So our food service program does require restaurants and things where they serve food to the public. There's regulatory parameters for that, and then our food inspectors do go out and inspect those.
But under a, probably a different
That's
mandate.
under environmental health.
But not under, I guess I'm asking specifically about health services, healthcare services. Does the department regulate, oversee, monitor any?
No,
healthcare
we do
services?
not. Those are regulated at the state level.
So just as needle exchange is regulated at the state level.
So it was a good point that Bradley brought up there, which was, these things are regulated. There are regulations on them there. And that the closest parallel is also something that's regulated at the state level. And so very, very interesting, I think also kind of telling. Now, that doesn't mean that there shouldn't be some sort of regulations locally. I just think that he's pointing out that this is sort of net new and a little odd for the discussion at play here. So, one other discussion point that I thought was interesting was, are there any similar ordinances being proposed in any other jurisdictions in Washington? Bradley points out that this change in state law took effect January 1st. So this was only possible because of the state law change. And obviously ours was presented January 8th. So just like barely a week, and, we've got this policy in here for it. But he had heard of rumors in other cities and counties possibly doing it, but nobody has done that yet. And so here we are. We have this shift to questions to submit. So Jamie's kind of fulfilling the first part of his guardrails here that he is put on. Sorry, Chairman Lund. I'm trying to refer to people by their last names to make this process actually, advisory in its capacity. But one of the interesting things that came out of this was board member Meckle sharing their sort of lived experience regarding this direct issue.
And we have some new members on this board that I have not had the opportunity to really get to know. And so I come to this conversation with my own lived experience as being addicted to opiates for a number of years. I'm going to be 37 this year. Never thought I'd make it to 30, let alone 37. I'm closer to 40 now. It's needle exchanges and access to medication-assisted treatment. It's the only reason I'm alive today. And I'm alive without any long-term diseases that put my health at risk. So when I think about the question of, do we want needle exchanges in Lewis County? For me, it is an enthusiastic, yes, absolutely, always they should be here. Thinking about the very dangerous impacts of this ordinance as written, I think it will cause serious harm to our community in a variety of different ways. I hear people saying, we don't want to see needles everywhere. We don't want to see them in the parks. If this passes, that is what will happen. Folks won't have a place to take them. They won't be, and aside from the litter and the public nuisance that can be, everywhere, I think about disease rates, right? We heard Cole say that when they do mass testing events, about 50% of folks are coming back positive for hepatitis C. What do we think is going to happen if people don't have access to clean syringes? And when we think about cotton and cookers, they go hand in hand. Because if you have a clean syringe, but you're still sharing cotton and cookers with people, you are still creating the environment for diseases to be shared. I also have very serious concerns that none of this is based in current research or evidence-based best practices. So
Well, we can certainly get to that on the specifics of claims that we want to offer forward. So.
Okay, so I feel like that was it's pretty amazing to have somebody's lived experience that's directly related to what the topic of the conversation at hand. And like I said, this meeting was 2.5 hours long. It's really hard to condense what everybody talked about without, getting way out into the weeds. There was a lot of good questions. Some things that board member Rohr and Iverson had were about school requirements and the distance from schools and later libraries and parks. And I felt like those were, relatively reasonable to some degree discussions to have. I mean, nobody wants this stuff near a park. Nobody wants, those things. So I think there's a lot of room in here for agreement for people to kind of give and take a little bit. Meckle points out that, they don't want to see needles in parks. and basically state that some things that they see in the policy they agree with, and some things they think would really do harm. Chairman Lund makes a crack about, well, we could ban needles, and then he's like, oh, wait, we've already banned drugs, and obviously we're right in the middle of a huge drug epidemic. Then one board member, and I'm not quite sure who it was, I apologize, I can't quite discern differences in voices there. It might have been McDougall or oh man, I can't remember the other board person's name, but basically they were concerned about, well, is Gather the only one that's going to be impacted by this? Will this affect other entities, and so on? Spradley had comments regarding this, being kind of perceived as an attack on Gather. He talked about something I thought was interesting: perception versus knowledge. The way we perceive something versus what we actually know to be true can be very different. Some questions about, like, why are we doing this now? And Lund kind of brought up, I think, a cornerstone of where he was kind of hanging this stuff off of, which is what's in the public interest? Is this in the public interest? Is it not? And so various topics. It went on and on and on. I mean, kudos to the advisory board. They really put in a lot of work on this discussion. I feel like it could have been more effective if it had been maybe prepared for better, not by the board, but by the information sent to the board. I also think it would have been better if somebody who was aware of the reasoning behind things, the policy questions, was there to discuss this. I think it would have been a lot more useful. There's two more clips that I want to share that came out of this meeting here.
Well, the RCW 695612 does talk about how the cities, towns, and counties and municipalities can enact laws and ordinances relating to drug paraphernalia, and we can regulate harm reduction services. So I would say
there certainly
we
is
are allowed
room
to
for
do
the
that.
county to take additional steps.
Yeah.
I mean, so superseding means we can't do something that the state says you're not allowed to do, but the state doesn't tell us everything that we can do. A lot of times it's like big parameters.
Well, it
and now
says
you
that
get
we
into-
cannot exceed what the state does.
Correct. Right. Yeah.
I think the question on the table for me is the ordinance that's being proposed, is it helpful at this point? Or as Galen said, and I agree, where I think the state regulations do an appropriate and adequate job of regulating needle exchanges. And speaking as an at-large member of the public, it feels like this ordinance is specifically just to go after Gather, which is a pattern in this county of trying to target some of the services that they provide. So that for me, it's I'm not sure that this ordinance as proposed is actually helpful or necessary. If there were reasons why we needed to put in county regulations, and Elizabeth, I appreciate you citing that RCW, counties can, not must or shall, right? And so the option is there if there's a problem that needs to be solved and the county can step in and do that. I don't see this ordinance as doing that.
I agree. It seems like we're missing a problem statement that this ordinance is intended to resolve.
Well, and
So a lot of good discussion there on is this needed? Is it necessary? Moving on to the next topic here.
So I guess I'm having a hard time with this because we're speculating on how they came up with these policies. We don't know what other data they looked at to come up with these policies. We don't know what they investigated. We don't know what studies they looked at. So I think we're speculating in how they came up with these things, and without having them in front of us to ask, how did you come up with this? I think that we shouldn't be doing that.
Yeah, point taken. And it's, let's say there's a lot of thought and intention that went into the decision around prohibiting a mobile exchange. And we will learn that probably at the Board of Health or the county commissioners hearing. Not trying to speculate and say that they didn't, because you're right, we don't know. Just saying if we are going to have an ordinance, the advisory board to the Board of Health says, we think that ordinance should be based in, from my perspective, evidence-based best practices. So point taken, not making a judgment on how it came together, raising a lot of questions around it and saying that is the lens through which, as an advisory board member, I would hope our Board of Health is viewing this issue. Does that help?
that makes sense. Yeah. And I wouldn't take it as anything else. I mean, maybe their answer is, yep, we did. Maybe
Well, I
not.
don't-
I mean, we get to the specifics, we would have other conclusions maybe, but
So a lot of good discussion there on obviously the purpose of this or what's going on and not speculating. That was the person that brought that up, I believe, was board member Iverson. And I felt like maybe they were bringing that up as like a defense, but I also see that as like a deficiency of this whole process, which is that it's just could be seen as being very uninformed regarding the intentions behind, well, this ordinance. So
I don't see this ordinance as being something that has like a punishment or something for the providers. I think it's more of a guideline.
There's a penalties section
Yeah,
that is
penalty
pretty
section
lengthy.
said the third violation and all subsequent violations of this chapter shall be a misdemeanor punishable prescribed LCC 1.2.
Yes, but it's not more than what the state already provides. It isn't. They already have misdemeanors for it.
no, this is more restrictive than the state policy. But we're not really at this point talking about the ordinance. We're talking about our views on what an ordinance ought to look like. We can get into that as far as what is the public interest that's being addressed. Is it properly being handled by elements of the deal? But certainly there were more consequences for a provider of these services under this ordinance than there are under the current state law. I mean, otherwise there'd be no point in having it.
So I feel like that's a very important point to draw out here is and this is when I refer to this as a punitive public health policy. This is kind of what I'm talking about, and I think it will become more clear later on. And hopefully I can get through these things quicker here. But yeah, this is got some teeth to it. It's almost like a type setting people up to. Well, honestly, it feels like it's being a setup to arrest like Cole or Patty or somebody, a sort of gotcha thing where not only are there these penalties with it, but they can also be enforced by law enforcement and whatever. And this is something that the advisory board is kind of claiming that they don't normally see in this fashion. So this last clip, I think, is probably a very important one that I want you to hold on to for the remainder of this conversation.
Well, no, we're again giving them an overview guide. We want to make sure that as they change this, and I suspect it's going to change more, or at least that's the whole point of having a hearing, is that that these are the things that we want to make sure are protected.
Okay, so keep that in mind. I expect that these things are going to change more. That's the point of a hearing, and he may be a little disappointed in that. And so then there was an abrupt motion to adjourn by board member Rohr. They hadn't even gotten to discussing statements regarding the specific ordinance at hand, but it was a 2.5-hour meeting, and so they adjourned. The next meeting that we go on to here, and you're doing so good listening to me. Thank you for hanging in there. I feel like this is worth it because I think it reveals a lot about our processes going on at the county level. And so this is the March 11th meeting that we're going to move into here, which is the Board of Health. This is where Chairman Lund presents the process and approach and what the advisory board had worked on and presents that to the Board of Health, which is made up of our 3 commissioners. He does ask for a formalized request next time. He says, there's very little guidance in this. He kind of relayed the information in talking with Cole. And so he shares with them kind of what his plan was to formalize a series of statements. And these statements are as follows, should there be a needle exchange in our county? That was one that they all, or most agreed on, the majority agreed on. The second one is there any public interest in having some elements of some regulations in them? That was the second one. The third was any ordinance that's created shouldn't jeopardize the existence of current entities that are providing those. And then it gets kind of more granular from there. The first of those would be that regulations on needle exchanges at the county level should follow evidence-based practices with regards to needle exchanges. Next statement is needle exchange regulations should take all steps to follow best practices to reduce potentially dangerous litter. Next statement is the public concern about proximity to schools and parks should also be considered. Next is registration of needle exchanges should not be seen as an application for approval. Basically meaning that, like, is it registration to get approved, or is it just an application so that you're documenting that you're an SSP? And then the last statement that they were able to have a majority vote on was information gathered from registration and data submission should not contain personally identifying and protected health information. And so then this kind of shifts gears in this meeting to the Board of Health, the commissioners, asking questions of the advisory board. And the first one kind of opens up with Pollock, who has, well, many questions throughout this whole process and has had many questions. So I'm going to try to get through these clips as fast as I can, but they are important to note here. So let me get this one set up. I apologize. Here we go.
Because my question would be, what problem does the Public Health and Services Advisory Board see this particular ordinance addressing?
Okay, so like that's her first thing, and this is, you know, also kind of reflected by the advisory board as well. Yeah, I think this is kind of the big elephant in the room. Like, what is guiding and driving these principles here, and what is hoped to be addressed? And at this point, in all of these meetings that I've detailed for you, nobody knows. You know, Bradley was the one that drafted it, but his marching orders were, what can we defend legally, not what should we do or could we do? Yeah, and it kind of goes from there. Then Pollock has some questions on infectious diseases, like, you know, are we going to see an increase if we implement some of these things like that? And so then we get into this.
Looking at the articles that we've reviewed, it would seem to indicate that barriers to access to clean needles would increase. Certainly, potentially, you can't always prove a negative, but that would increase from studies that have been done that were presented. I think even the advisory board was, the articles were made available to them that showed that it decrease the disease burden in the community.
Okay, so yeah, there is a decrease. They get into mobile exchange.
What is the advantage of having no mobile service?
I don't know that there's any advantage to having a no mobile service. The disadvantage of not having a mobile service is that it puts the current situation into the inability to provide the needle exchange.
Okay, so mind you, I'm just trying to capture the salient points. There was a lot. I mean, this is hours and hours of meetings here that I'm condensing into things. And if I miss something or misspoke, that's on me. But just, you know, be aware that there's just a lot of questions around this in like every meeting that it was presented in.
If we say and continue with this statement that no mobile service, then that would functionally put them out of business in providing services to our community, our county. It also would limit them to be able to go to other areas in the county as well. And if we truly believe that this is a service to those that are in this kind of situation, then it would limit the benefit of that, you know, as far as disease reduction and that sort of thing.
Okay, so, you know, he's talking about here, you know, these benefits. I just want to stop real quick and say, doesn't Dr. Wiley have just like a nice, soothing voice? Like, I feel like he should read like children's books or something. I mean, just imagine listening to that voice reading you a bedtime story. It's just like kind of magical. And none of that has anything to do with this meeting. I just really appreciate his the gentle timbre of his voice. Anyways, they go into more questions. There are discussions of drug paraphernalia. Pollock makes a point about being unique in the way they assign criminal penalties for this thing, for a healthcare service. And Bradley kind of pushes back a little bit and says, "Oh, I wouldn't state it like that, or I wouldn't phrase it like that." But then he kind of goes on to talk about something that is regulated at the state level, not usually at a county level. They get into the 24-month requirement here.
So I think that this ordinance effectively shuts down Gather because they don't have a brick and mortar facility that they do the exchange through.
There, that's my bad. Sorry, that was a previous clip I meant to play. Now we're going to get to the 24-month requirement. And reminder, this is just the requirement that people can't work for an SSP if they've had a drug conviction within 24 months.
And then what is the significance of 24 months clean time? Is there a evidence that says, yep, after this period of time, but if you were engaged in this sooner, that you have an increased risk of relapse?
I don't know of any significance of that 24-month. I didn't follow that in the reading that I did, but it did state that involving people who have been there, who have maybe knowledge of the people, maybe have more influence about getting them involved in services, especially if they've participated in services, that can be a real bonus. And I don't mind a 24-month in there. My concern would be, could there be exceptions? Could a person apply for an exemption or something, if that could be worded in here, based on the leadership that says this person has proven themselves in so many ways?
So just kind of pointing out, would be very unique criteria here that really isn't imposed anywhere else. And is usually left up to the discretion of the program operators. So, that it's in here is kind of interesting.
They're not handing out drugs. So it's not dispensing drugs. They're dispensing clean needles. And what they have been doing is some of the other paraphernalia for the purpose of decreasing harm in regard to infection as well. And there's an article that really supports, and John has access to that, our deputy director, and he sent it out to us, pointing out that, the cotton, when you talk about cotton, you often think of a cotton ball, but these are about the size of a BB that is real tightly woven and that they draw through the needle. And in the kits that I saw, there were like, I don't know, maybe 20 of those cotton beads almost, because that can be a source if they reuse them. A source of infection, bacterial infection as well. Not that we're trying to encourage them to use it, and fortunately the demand is going down, but unfortunately because of fentanyl, it seems to me like that limiting and say no additional paraphernalia does limit that.
Okay, so discussion on paraphernalia. So one thing I got to say about trying to recap these meetings, especially if it has Dr. Wiley in it or Sean Swope, is that have a tendency to have run-on sentences and long, circuitous routes through an answer. And so if you catch me jumping things here, it's because they change topics and then they eventually pick up topics again, things like that. So this next one, I believe, gets back on peer workers.
I will say that currently peer counselors and SUD professionals, they don't need to have any significant time in recovery. Personally, I think they should have some significant time in recovery. As to how much time, it's very subjective. So since there's no limits on anybody, say I am 3 months sober and I want to go to school to be a peer counselor or take the training to be a peer counselor, I can do that. There's nothing that is going to stop me from doing that. So that was, I don't think that it should, personally, I don't think that it should be applied because it's not being applied to any other agencies that are offering substance use treatment for their employees.
So I think this is a good point, which is basically that this would only apply to SSPs, which would really effectually only apply to Gather. It's not something that's industry standard or considered best practice. It's usually left up to the discretion of the program operators.
Where we require peer navigator services in other elements, and I haven't seen any 24-hour or 24-month requirement on those. I'm just wondering.
I didn't know where
how
that came from. I didn't know if it was arbitrary or just trying to be safe. But I would think that those in charge of the program are very much aware of those that are doing well and those that aren't, and could be kicked off at any moment if they're noted to be using on the side or something like that.
So it remains a mystery. And finally, it sounds like the person that drafted the actual policy part of it has something to say on the 24-month requirement.
I gather.
So I've asked several of our providers, like Destination Hope and Recovery, Community Action Council, Coastal Community Action Council, if they have a requirement for people before they allow them to become case managers working with people that are in addiction, and they do set up timelines, and typically it's that 24-month period, 2 years out type of deal. And so I think it's just, we want to protect those that are in active recovery, because the way that I see it is, you may not be around the drugs, but you are around people that are actively using drugs. And so if you can somehow put a firewall for time and distance and allow that process to take place, I think that's good.
Okay, so this is the justification, which was Sean Swope asked around, and this is what he got back. I find it interesting that this would then be turned into a, it sounds like it is a maybe standard operating procedure for the people that he asked, maybe. But then he wants to turn it into a regulation on these SSP programs. Make it make sense. I don't know. This is very odd, but the next part gets worse.
I mean, we had a graduation a few months ago for drug court here, and that person passed away. So, I mean, it's just one of those things to where we want to help people.
Okay, so this part he's referring to, and I'm going to name names, Blake Hansen. Blake Hansen was a drug court graduate who died just very shortly after graduating drug court from a fentanyl overdose. Why I decided to share that was for a couple of reasons. One, normally drug court graduations happen over at, I think, Judge Toynbee's court or something like that. But it's usually they have their own thing going on. If you follow drug court on Facebook, and I recommend that you do, you'll see a lot of really cool pictures from graduations or events or different things like that. But typically it's held over there. For some reason, for these particular graduates, I think it was 2, it might have been more, they moved it over to the Board of County Commissioners room. They had a big thing. They invited the paper. There was a write-up on it. It was just this big event. And then shortly after Blake Hansen passed away, the reason why I find this pretty offensive, there's multiple reasons. First of all, Blake Hansen died of a fentanyl overdose that doesn't involve, it doesn't involve Gather. It doesn't involve the SSP. He was a graduate of Swope's, blessed program here. And if you go back and listen to my previous episodes, I'm a proponent of drug court. And so him taking this and then using it as a justification to add a requirement on a regulation to SSP programs, which only are operated by Gather right now, and as far as I know, are only going to be operated Gather, seems rather offensive to me. And Leah Rader commented on this on Facebook, and I will post her Facebook story, but basically she was extremely frustrated, especially about this ordinance as a whole. She shared that she had been an intravenous drug user. She had contracted hepatitis C, and she had been treated and cured of her hepatitis C using Gather Church services. And furthermore, for him to use an issue with Blake Hansen, which is her family member, as justification for turning around and creating some sort of punitive response, to SSPs and to Gather, it's just, it's gross. That's really all I have to say about that. It's gross. I find it interesting that he doesn't seem to be turning around and providing this restriction for, drug court. He doesn't seem to be, imposing this restriction on Destination Hope and Recovery, which is his RNP program, or on Salvation Army. No, he's decided this needs to go into restriction on SSPs that Gather operates. It's just messed up, and it kind of continues to be weird here.
While we're working on this, actively recruiting SUD treatment, the mobile clinic from the Chehalis tribe, trying to get them to come down into service our area using Suboxone and trying to figure out what's actually working.
So let me get this straight. You're currently advocating for and trying to pursue the mobile services of the Chehalis tribe, at the same time pushing forward an ordinance that would effectively strip Gather's ability to operate in the same mobile fashion. Why? I don't believe this ever gets spelled out, other than some very broad idea of what he'll call accountability. And we'll get into that.
When you start reading about, I keep hearing, the best practices and whatnot. Well, there was this landmark study that was done up in British Columbia for safer supply, where they said that because they were providing safer supply, that they had less people that actually died because they gave them safe drugs, heroin, fentanyl. But the other piece of that is they're also at the same time giving them high doses of Suboxone as well.
Okay, so I don't understand what this really has to do with anything. So I emailed Swope, and he was kind enough to provide me the resources on this. And what he did was provide me to a link to a Substack post, like a blog post, which then had a link to the actual study. But there's a few things. One, this is just a Substack article. Second, the actual study that it's addressing is regarding safe injection sites, which isn't even in play here. This isn't even an issue that we're having to deal with. It's literally nothing to do with it. And then third, the article that he linked to appears to be critical to many harm reduction methods, naloxone, medically assisted treatment, and so on. Harm reduction services he's actively involved in promoting and supporting. So, I'm really confused here. Talking about this landmark study that has to do with something different than the topic at hand, which is SSP, which is the reduction of bloodborne pathogens in the community. And this has got to be one of the most frustrating things about him that I've always struggled with, which is he finds something unrelated over here, he pulls it over here and uses it for some sort of thing here. He has no concept of nuance, or even he just throws them all together. He sent me several other links to resources, and I don't have a problem sharing them with them because I just don't know what they have any bearing on this topic at hand, unless, of course, you just smush it all together based off of what you're feeling that day. He sends me another Substack article that's also not addressing SSP. It's also not a study. And it ends with this: harm reduction at its base approaches addiction and the problems that stem from it as medical problems. ones to be solved by experts and the collective rather than individual spiritual problems. Some of us believe this approach is destined to fail. So like this is talking about harm reduction in general. Does that apply to Destination Hope and Recovery? Does that apply to Salvation Army or anybody else? MAP programs? Another article he sent me by, quote, the Bureau was also not addressing SSP and also was not a study. It was about safer supply opioid pills showing up in an RCMP bust. Totally unrelated to what we got going on here. Just like he grabs this, yeah, this is the problem we have here. He's really hyper focused on safe injection sites and safer supply stuff, and it's not in play. It's not even on the board. So I don't know why he looks at this, grabs it, I'm going to say misunderstands what's going on, and then uses it to push through some sort of ham-fisted, weird policy. Another article he sent me is by the National Post, and it's also not a study. And it opens with this. It says, regular readers will know that I support harm reduction strategies to address the horrifying death toll from opioid addictions, notably supervised injection sites and the provision of pharmaceutical-grade alternatives to potentially fatal mystery cocktails for sale on the street. I read that. I was just like, did he read this before he sent it to me? And that article ends with like blaming harm reduction for the opioid crisis is like blaming vaccines for COVID-19. I'm not convinced he read this article before he sent it to me. Very weird. And maybe I need to read the article closer, but none of that matters because these aren't things that are in play here. Another from North America Recovers that he sent me, also addressing government drug sites. So once again, not the same topic. He sent me an article from Vancouver City News, and it's addressing, you guessed it, a safe injection site, which is not something that we're dealing with here. Another link was an op-ed on AEI on safe injection sites and crime. And then he sent me an opinion piece in the New York Post. In it, this is part of what the author shares. He says, as a former heroin addict, I utilized needle exchanges and likely avoided HIV because of it. In fact, I was accepted into a detox center through a needle exchange program in Los Angeles. This was years ago, however, when the harm reduction movement went hand in hand with treatment. So they sent me an article, once again, from the New York Post, which, by the way, Wikipedia says the New York Post is an American conservative daily tabloid newspaper published in New York City. He sent me a tabloid article that praises the author's use of harm reduction needle exchange service. And it's from the tabloid. I mean, this just reminds me of that movie, So I Married an Axe Murderer, where the son is arguing with his mom. She's like, can you hand me the paper? And he's like, this, and it's Weekly World News. And he's like, Mom, I can't believe you refer to this as the paper. And she's like, what's wrong with this? And he says, the paper has facts. And she's like, she points to it. It's got a picture of a pregnant man on the front. And she reads the headline and says, pregnant man gives birth. That's a fact. You know, I feel like we're dealing with the mother in that movie. It's a great movie, by the way, cult classic. Definitely go out and watch it. Very odd. I mean, this is just, these are the secrets behind the policy, I guess. And personally, they have been weighed and been measured, and they've definitely been found wanting here. So I will move on to the next clip because this is getting ridiculous.
To me, I don't want to see another person die. And what currently is happening in Lewis County, all over the world, is you see this isn't working. We say it's harm reduction, but we still have record high number of people that are dying.
Okay. So now he's kind of shifted, and this is like what I said he does. He finds something that's about this topic over here, and then he just kind of like folds that into some sort of broader thing that he's talking about, or he shifts gears somewhere where they're not talking about the same thing. So now he's apparently going after harm reduction, like in general. I don't know. Very odd.
I mean, perpetuating it, that vicious cycle is deadly. And we see it time and time again where people are overdosing. At some point when someone overdoses and they don't have a person to help them with the Narcan, and then they die. Well, they were hopeful that they had the Narcan there, but they weren't able to get access to use it. And that's, it's heartbreaking. And we have the RCWs that we can regulate it in the county. And I think that's what we should do.
Okay, so in this word salad of a response here, he's talking about Narcan and that some people have it, but they don't have it when they need it, but they couldn't use it because they had I don't know what he's saying. And right before this clip, I was going to include these clips. I decided not to because I'm already like way too long on this thing. He talked about mandating blood tests. If somebody came to get syringes, they also have to have their blood taken. And then if they're found to be HIV positive or whatever, maybe that should be sent to the CDC or the Department of Health. Like just really weird, way out there stuff. Certainly for somebody who considers himself a conservative, that you would have to mandate a blood test to participate in a syringe exchange. It also shows that he doesn't understand why syringe exchange are low barrier. And then he talks about like, we can't just focus on this group of people. We need to focus on the whole community, which is also frustrating because this is focused on the whole community. Like I said, the point of SSPs is to address bloodborne pathogens and their spread. That's its core services. And then it has its extended services or wraparound services that have other purposes as well. And so I don't. Next.
When we should make sure that we have strong accountability, because this is, I don't know, playing roulette. You're allowing people to engage in a behavior that has become very deadly in our world and in our culture.
Okay, so who's allowing this behavior? That's what I want to know. He's acting as though providing clean syringes is somehow allowing drug addiction. Yet we know that drug addiction exists whether clean needle syringes exist or not. And that's not the point. The point of SSPs is to reduce bloodborne pathogens. I'm just going to keep saying this over and over again because maybe he'll listen to this and maybe he'll find out that like he's just being really obtuse on this. This idea that somehow like Gather is responsible for addiction. Like, how come he's not approaching law enforcement with this problem? Are they allowing drug addiction? Are Destination Hope and Recovery, his RMP program, are they allowing this? Is Salvation Army allowing this? It seems ridiculous. It's like saying that, the existence of contraception and prophylactics, condoms, if you will, are generating somehow the need for people, the desire for people to want to have sex. He's completely ignoring the fact that kind of sustains itself. Like, you don't have to encourage people to have sex. That's not a problem that's going on. And somehow that these methods of contraception or protection from STDs are driving this sexual urge and desire in couples. I mean, or not couples or anybody. I don't even know. Like, it just doesn't make sense in how he's addressing this.
I'm incredibly proud of the work that has gone into this ordinance. And I think it's very well thought out. So I think it's something that is thinking at the community as a whole. And I appreciate that the time that the Board of Health took to provide these questions and, just even writing some of the different comments down that I've heard today. I'm going to talk with Robert the next week and just taking these things into consideration.
I don't know what he considers taking into consideration, but the end result was there's little to no changes in the proposed ordinance, and he says as much. So basically, the ordinance that was presented on January 8th is changed in minor ways or some sort of thing like that, but ultimately it makes it through a advisory board and a public health officer and questions from that advisory board and the board of health, and like somehow through this whole process, this thing has remained relatively unchanged.
Well, one of the things, Commissioner Swope, is that the harm reduction isn't stopping them from using, is to keep them from getting diseases that if they do recover, they have to deal with. And that's, or keep them out of the hospital, keep them out of medical services.
Wiley gets it.
This is different. It's not dispensing of drugs. And the other thing is, these are people that are coming kind of out of the hiding to get help because they see that there's a benefit that this might prevent me from getting sick, or if I am sick, spreading it to someone else because we each have our own clean needle. But it's also a source of contact to introduce them into therapy. And I think that's the part that if you don't have the needle exchange, you don't have that contact. And no contact, no impact. And I think that is something that's being missed here, is that, you know, it is not Gather's desire to see people continue to use drugs safely.
Man, Wiley's on a roll. Keep going.
But there's an opportunity to introduce them to therapy, and being a faith-based work, even to, you know, saving faith too. So to me, it's not like some person who's trying to push clean injection sites or safe injection sites, or let's have our own drugs for these folks. So I'm thinking that to make their ministry streamlined and not restrict it would be best.
This is not a ministry. Just want to be very clear. A needle exchange program is the farthest thing from a ministry. It's not something that Jesus would do. He's not out peddling an opportunity for people to get drugs. And the idea that we keep talking about it from that standpoint is highly offensive, because we totally missed the mark on that.
Well, I think they see it as a ministry, and people have a heart for these people that would otherwise not have that contact.
Okay, so personally, I would have preferred that the whole topic of theology or what is a ministry had, you know, not been broached here, just because it's not pertinent to the issue at hand. But I do think that it is revealing in terms of, I'm going to say, a type of animosity toward Gather. Just the idea that you just hear Swope's voice change. You could hear like the anger in there, and what a weird take. I think though the reason why I included this is because I think that it sheds even more light on this whole bastardized process and what's going on here and the outcome that we're getting from it.
Did you know that on a weekly, bi-weekly basis, our Destination Hope and Recovery team, along with our coordinated entry team at the Salvation Army and law enforcement, they continually go out to different areas in our community to make that contact, to provide services, to ask people if they want to engage services.
Okay, so I want to talk about this because those are all things that Gather used to do. Before Swope committed what I considered tortious interference into Gather's contracts and, you know, engaged in a public, propaganda campaign basically against Gather using the long arm of the government and the platform that the government provides him. if you want to listen to something, I know this is already a super long episode, but when you're done with this, and if you haven't listened to my former episode 11, Swope Needs Our Help, go listen to it, because everything in that episode still stands. All the lies that he told on KELA, all the things that he claimed the Gather was doing, committing, medical fraud and billing, fraud and all this other stuff. All those things that he said that he threw out there on KELA, that he was, made these great accusations, nothing came of it. Nothing ended up being true. Nothing ended up resembling reality here. So when he talks about accountability, it kind of pisses me off, because accountability is a word he uses to punch down on people, and doesn't stop and recognize that he hasn't faced accountability for the things that he's done. And he was on there with Chad Taylor, the publisher of the Chronicle, and Chad Taylor made his jokes about the homeless industrial complex and how much money you need, more public money so that you can buy more buildings and make them into more churches. And here Chad Taylor's over here. He accepts public funds through the Economic Economic Alliance of Lewis County. There's all sorts of public funds that go to his silver agency to pay for websites and different things like that. And he had the gall to sit there and speak on things he has no idea about what Gather does or how much they had or whatever. And here we are talking about a program that Cole has pointed out is like $20,000 in public funds. So we're talking about accountability here, and I have yet to see the lies, the misrepresentation, the abuse of power, any of that face any sort of actual accountability. I don't think Swope knows what accountability is, because every time he sees it, or every time he says it, it's something he puts on the end of the stick to go beat Gather with. And yet he has not faced any accountability for the obvious lies and misrepresentation and tortious interference that he's been involved in. It's very frustrating.
I'm just saying that we have to stop lowering the bar and raising the bar, and to provide real services that are going to help people get well, because what is happening right now is not working. And the studies show it. I mean, if you look at what's happening in the Vancouver, Canada, and what they're doing, it is falling apart. They went to a needle exchange, and then they went to a paraphernalia. Then they went to safer injection sites, and now they're giving out safer and clean drugs, and it's falling apart. And so, for me, I would like to see people not have to continue this vicious cycle. So
you're considering it like a slippery slope. We're headed that direction. Let's stop the slope, the slide.
Very slippery slope. And we're seeing now that Oregon, they're reversing their course. They decriminalized, and now they're even advocating for involuntary treatment.
But law enforcement is involved with that, right?
In which part?
Involuntary treatment. There's no way you can force that without law enforcement.
I've not read much. I just read a couple articles on it recently.
Did they pull back and no longer have needle exchanges? I mean, to stop the clean injection sites, to stop the clean, pharmaceutical grade drugs that they're offering to the addicts or vending machines or whatever it might be. How far back are they pulling it? What are they coming back to?
All I know is I believe they recriminalize drugs. I have not read more about it. I've been reading more on to do with what we're dealing with.
Okay, so that was an interesting exchange where Swope made some large claims, also want to point out, unrelated to the purpose of an SSP, saying that these things aren't working, everybody sees it everywhere, and they're pulling back where they used to do all the stuff. He also mentions programs that, once again, are not in play here. And then when pressed to, well, what are they doing or what are they rolling back to, he basically says, I don't know, I just read a few articles on it. And this is what's driving our local policy, is half-baked. I mean, oh my goodness, this is the Weekly World News Garth Brooks juice diet type levels of bullshit. This is I'm gonna move on.
And in no way are we banning a needle exchange program. We see what's happening. I've talked with people in Olympia about the needle exchange program there. You have people that just ride around on their bicycles and will go from different places. It's hard to provide that accountability, and was encouraged that keeping it in a brick and mortar, a place where everyone knows that this is where the needle exchange place takes place, the community is more receptive for something like that because there's stronger accountability. They know that it's happening right here. And it's not happening in different little pockets that people don't know about.
Remember what I said about accountability being a stick that he uses to beat gather with? This is the same thing. He's talking about that they need, he doesn't define it, but accountability, the reason for requiring a brick and mortar is that these extended services are provided alongside the core services right there. Now, first of all, Gather's already doing that in their mobile fashion. There are ways to, they go out, they have a doctor, they have nurses, they have peer counselors, they have all sorts of stuff. But then my question is, if this is what you really think is accountability, are you applying the same accountability to Destination Hope and Recovery? Are you applying this accountability to anybody that goes out as some sort of service provider, or the Chehalis tribe that you were just praising for their mobile unit? The answer is no. It's just this SSP. It's just specifically Gather.
Another thing I think we maybe need to consider regarding the needle ordinance as to what constitutes effective. And I believe the main purpose for needle exchange is disease reduction. We'd love to get people into treatment. We would much rather have people not dependent upon IV drug use, period. But our main purpose with needle exchange, as my understanding, is to reduce our incidence of bloodborne disease.
So here we are with Pollock kind of bringing it around again, if you will, and, bringing it home. And then that's there's more to that meeting. Obviously, these things go on and can go on forever. And we end up then finally here at the March 13th director's update. All of this. And at this point, I want to point out that the notice of hearing regarding this thing is still referring to a very old revision or copy of this ordinance. So the public still doesn't have a copy that was even provided to the advisory board. And so they asked him, was there any significant changes? And he said the only significant changes are libraries have been added to the list of 750 feet from a location. Some stuff around a person being under the age of 18, the ID must be checked if it's suspected. And then some discussion on the one-to-one regarding estimations that are over 10, if it's over 10 needles, estimations are fine. And so once again, Pollock expresses that she has concerns on this ordinance as is, the mobile restriction on a large rural population, a one-to-one requirement goes against best practices, that there's no significant basis for the 24-month restriction, offers 12 weeks as a compromise. And I think that's fair. And I think everybody could probably agree to that. There's some quibbles about what counts as valid ID. And she kind of ends with this. The other, probably the biggest issue I have with this is the assignment of criminal penalties to our healthcare of attempting to limit bloodborne disease. And I do not think that we should open that door. And so they move to do a dual adoption of the agenda. Everybody approves all the other remaining items. And then this item is then brought forth, and there's some discussion about, once again, just like at the very, very, very first meeting, it's repeated here at the end of this, about what is the purpose of a notice of hearing. And it's to provide the public with a near final form of this thing. And she also points out that we're under no emergency to get this adopted, and I think that's a great point. There's a lot of finagling to just get this thing through, and there has been this entire time, and sadly it goes through this whole process that was basically forcing Swope's hand, and at the end you still have something that just barely modified version of what he submitted first, despite an advisory board and a public health officer and a service provider all weighing in on it. And so there's some, kind of shifting around on this, and anyways, it goes on. And so, yeah, this is me trying to succinctly whittle down what I thought were the salient points of all of the discussion across these 6 different meetings and stuff. And the vote is this coming Tuesday. What would that be? The 19th. And, at this point, my experience with the county has been that it'll probably go through. I hope not. I hope that saner heads will prevail. But my experience has been people just either don't do anything or they just get on board. They go along to get along. But I think it's important. The reason why I did this wasn't because I'm against some sort of regulation for SSPs. I really don't have a dog in that race there. My concern is just the ongoing oddness of how Commissioner Swope in particular pursues not only his ordinances, but his processes for implementing those ordinances. My concern is that we have a commissioner that has just repeatedly, time and again, showed that he has no problem abusing his authority to, commit punitive acts against Gather Church. I also am frustrated that he never seems to face any sort of accountability for his actions. He just moves on to the next thing. I've made a joke that he's got this wheel of misfortune that has 3 slices on it, which is, big government and liberals, and then maybe Gather, and then the third one would be the gays. And he just spins his wheel, and whatever it lands on is who he goes out to generate community outrage over, usually without information, usually without any sort of context, and usually misrepresenting, kind of what's been presented or what's going on. I am frustrated by that. It's not good for our area. I think the people of Lewis County deserve better. I think people everywhere deserve better than this. This isn't just a Lewis County thing. I think our authorities should do better than this. I think those that are in charge of this amazing amount of power can do better than what we're seeing here, and than what we have seen, and that we've repeatedly seen. So anyways, this thing is almost 2 hours long. I apologize, everybody. I hope that this is valuable to you who are trying to understand more about the subject. And yeah, I'd just like to thank our sponsors, the Homeless Industrial Complex and Antifa. I'm kidding. I don't have any sponsors. So anyways, have a good evening or whatever time it is when you listen to this thing, and I'm out.